Relapse and refractory myeloma is really a very hot topic these days because actually we have many treatment options that are coming into this field, and obviously this is good news for our patient, but on the other hand it makes the physician role, I would say, more and more difficult because it's becoming extremely complex on how to choose the right therapy, but also the right sequence of treatment for a relapse or refractory multiple myeloma. And indeed, the focus of my talk was related to the management of a real-life case of rapidly progressing, or I would say high-risk relapse. And indeed, when we look to the overall spectrum of the different available options, it is clear that when you are handling this type of patient, one needs to bear in mind that you have to take into account some patient-related features, especially age, comorbidities, prior history, the bone marrow reserve, organ dysfunction. You have to take into account disease-related features, of course, high-risk cytogenetics, but also issues related to the manifestations of the disease. Obviously, it's a different story when you have kidney failure or hypercalcemia or medullary compression versus bone pain only or chronic anemia. Also, I think you have to take into account the kinetics of relapse, because if you have a relapse on therapy, for example, it highlights resistant disease. On the other hand, if your relapse is occurring 2 or 3 years after the end of a given therapy, obviously this patient may still be sensitive to the same therapy. Also, when taking this kind of decisions, you have to take into account the components of the prior therapies. So when you put all of these parameters together, it's becoming a very complex equation. However, on a case-per-case basis, I'm confident that we are able to identify what would be the optimal treatment for a given patient in a given situation. And we know that second-generation proteasome inhibitors, for example, do have a rapid mechanism of action, and they may be preferred in rapidly progressing high-risk disease. On the other hand, more immune-mediated activity, such as with monoclonal antibodies like elotuzumab, may work on indolent form of the disease. Then you have another monoclonal antibody, such as daratumumab, which looks like to give wonderful results in combination, whether with IMiD, lenalidomide, dexamethasone, or whether with proteasome inhibitors such as bortezomib, with a very rapid activity. So I think we have a very wide spectrum, different options, and we will be able progressively, based on clinical judgment, to refine the right sequence of these different agents. And at the end of the day, I believe that a patient will likely require these different options, and we should aim to find the optimal sequence that would allow to optimize disease response and survival while minimizing toxicity. And I believe this is feasible.